Thanks for inviting me to be here today. As was said, I'm the Director of Operations and Delivery, and so I'm going to give you a kind of unashamed look at some of the key challenges that the NHS is facing and how we're starting to respond to those, both from a delivery perspective, but also I guess speaking to the work that you will all be involved in, how we're bringing the power of kind of analytical thinking to help us solve some of the biggest problems that the NHS has got. I suppose to frame my comments this morning, the first thing I would say is that probably the biggest challenge that we face in the NHS is the management of variation. No matter where I look, no matter what problem I deal with, and I'm going from here to a session to think about how we're preparing for winter, I will go from there to a session on how we're recovering cancer performance for 62-day cancer. I will go from there to a session on how we're delivering referral to treatment standards in 18 weeks. And underpinning all of these challenges is the notion of variation in behaviour, both at a human level, so variation in practice of individual clinicians, variation in organisational performance, and variation in whole systems. Everywhere I look, I see that challenge. And I'm going to talk through, I guess, through two lenses this morning. One about, so what are we trying to do from a policy perspective to address that variation? But then I'm going to give you a very specific example of one of the key programs that we have, which is aimed at changing or working with individual GPs. We have about 7,500 practices in the country as we speak right now. And one of the key challenges that we have is in standardising their referral behaviour, optimising it, some might say. And I'm going to talk to you about how that can really liberate a huge amount of efficiency that the NHS is challenged to deliver. So there we are. If we get a chance, I might talk to you a little bit about winter. Happens every year, quite predictably, and every year the NHS seems to struggle to deliver it. I guess, as was said at the start, I'd like this session to be a fairly full and frank discussion. So I'd appreciate it if hashtag #Weldon said didn't get tweeted out of this room, because it enables you to ask me questions and me to answer them. So, what are the challenges? Well, here are 4 of them, just to contextualise what we are dealing with here. They are all hugely significant, and if we don't get a grip on them, then the NHS will undeniably go bust. Remember the situation. We are in a cash-constrained environment at the moment. We have been so approximately since 2010. Next year, for the first time, I think, well, certainly in my memory of the NHS, the real terms growth per patient will go down. And so the challenges that we face clinically, some of which are up there, have to be met in an increasingly resource-constrained environment. And the challenge which I'm trying to grapple with at the moment is, well, how do we do that? Can the NHS do that? I'm going to put my cards on the table and say, I think there is a huge amount of untapped opportunity in the NHS. And hopefully during this talk, I'm going to show you some of what that opportunity might be. And it's quite staggering when you look at it. So you can see there life expectancy going by an average of 5 hours per day. So while we are speaking this morning, you will all happily live for 5 hours longer, which is great. 500,000 more people over 75. that number is going to carry on rising. So the NHS is becoming the victim of its own success. It's literally the snake that's eating itself, because as people get older, as people live longer, which is a testament to the skills and dedication and technologies that we have available to us, clearly as they reach the end of their life, they need more complex care, they need it for longer. People with long-term conditions, as a consequence of the above, rising to 50%. I come from an operational background. I used to run A&E departments. In winter, I used to go into our medical admissions unit, and the average age of people in that medical admissions unit was over 90. Every single one of the 16 beds was over 90. And every single one of those people would have had multiple long-term conditions. But it's not just the elderly. So the other thing, of course, is that we are a society where, as it says here, at the moment, unless we do something about it, most of the children who we have with us at the moment will grow up to be obese. And the risks associated with that in later life, the cost to the NHS just cannot be borne in the current environment. So I frame that because it's both ends of the spectrum, both the elderly and also the young. So what are we doing about that then? Well, obviously here we are publishing some policy documents, but so over the last, you can see 3 years, what we're trying to do here is to reposition the way the NHS has worked. From the NHS's founding days, we were an organisation dedicated to treating illness. We have now got to reposition the NHS to treat and promote wellness, as well as be great at treating illness. And that was what the 5-year forward view set out. It said there were 3 challenges. It said we need to improve care and quality, we need to improve efficiency, and we need to improve the health of the population. To that end, we began then looking at, well, how do we reorganise the NHS to deliver those models? That's the Vanguards, and how do you actually make those real? Because we've known for years that the schism between health and social care, to take one example, the schism between primary and secondary care inhibits and creates transaction costs to care. We then moved to trying to create place-based partnerships, sustainability and transformation partnerships, and then finally this year we published the next steps on the 5-year forward view. And that again takes this journey of integration even further. So this is the policy context that we are operating in. What are we trying to deliver? Well, as all of us, I hope, have a vested interest, many of you hopefully will have used the NHS and had a positive experience of it. I don't want to hear the negative stories this morning, thank you. But here are some of the things that we are trying to deliver over the next couple of years. So you can see here, first of all, we've got UEC, that's urgent and emergency care. We're trying to make sure that as many people as possible go through an emergency department in 4 hours. It's a standard we've struggled to meet over the last couple of years, and particularly over winter. We're trying to improve mental health, experience of mental health patients in A&E. We're trying to improve the number of people who can be streamed away. Great many people still go to A&E departments who essentially have what you might call primary care complaints, or complaints that could be dealt with in another care setting. Mental health, we're trying to improve the access to psychological therapies. Cancer, we're trying to recover the 62-day standard. Primary care, we're trying to, everybody I think would have probably experienced this one. Can you get an appointment with your GP when you want at a time that is convenient to you? We have a big programme in terms of making sure access is improved, and then we're trying to make sure that we maintain the referral to treatment standard. That is my day job, just by the way. That's what I spend most of my time working. So in the introduction, these are the big transformation programmes, and these are the issues that we are trying to address. But you can see it's not just, there's both a horizontal axis here and a vertical axis. So We're trying to change performance, workforce, capital expenditure, service redesign, change the way technology impacts all of these areas. We can maybe talk about some of those later if people are interested in asking questions about them. So how are we going to organise ourselves to deliver? Well, people think, I think, that the NHS is actually, and when you experience the NHS, people think of it as a kind of single blue box, don't they? But in actual fact, of course, it's completely not. It is a loose federation of states. Each organisation has its own statutory accountability. So we have 140 odd hospitals in England. We have 209 clinical commissioning groups. We have a number of regulators. All of those have independent points of view. All of them have different ways of working, different cultures, different histories, and different information systems. So this, it's a to-be data and information flow, but it's unashamedly where we're trying to get to, because if an underpinning motif is of my theme this morning, firstly, that we've got a huge challenge, secondly, that we've got no more money to meet that challenge, thirdly, that the only way of delivering on that challenge is to integrate care in a different way. We also have to integrate then, don't we, the way in which we do the infrastructure. And this very high-level schematic, and I hasten to add it's not yet in place, in some areas it's starting to be, is a way of doing that. So here are our frontline services, providers and commissioners. The sustainability and transformation partnerships, which I'll talk more about in a minute, are a way of bringing together that very fragmented language of provision, that very fragmented set of organisations that are local to every one of us in England, and trying to make them work more effectively together. Here then are our regions. So the regions, we have 4 in the NHS England domain, so that's the North, Midlands and East, London and the South. You'll quickly work out, just even without me describing them to you, those are very large areas to cover. And then, of course, we've got information, and you can see here that we've got a huge amount of ways of collecting information in the NHS. If I was to leave you with one thought, I would say the NHS is data rich, hugely data rich, but still analytically we have got huge steps that we need to take. We are analytically poor, and one of the causes of that you can see up here, because we have a huge number of different ways of collecting information and very few ways of aggregating it in a way that helps us understand the needs of a population. So this here, this front line, is all about moving back to place-based commissioning, commissioning for a geography, commissioning for the health outcomes of a population. That is what we are trying to do. We're trying to move away from output targets, does somebody get seen within 4 hours, to outcome-based systems of thinking. Does somebody's health improve as a result of the interventions that a local geography makes? Here then is how we're going to try and coordinate the ask. So, you know, we've had hundreds of different targets, and I would stand here as somebody who both implemented many of these targets in my operational life and would defend them. They were publicly consulted on and they matter to patients, and it's important that we still deliver them. But equally, we've got to make sure we focus on the longer term, because if we don't, we will most assuredly again not position the health service for where it needs to be. So going back to the challenges that I posed, what does a system look like is a question we are now starting to ask. What services do we have to put in place so that 80% of children don't grow up to be obese? Because if we don't get that right now, 10 years down the line, those children are the young adults and the adults of middle age who then start getting those long-term conditions, who then start accessing the NHS. So we have to start positioning the NHS to act into the longer term. We've had an NHS and social care that's very focused on what you might call tactical interventions to achieve success. We are now trying to make it focus into a much longer term way of thinking, which involves all of us across all of the arm's length bodies thinking quite differently. And when we start talking about, well, how do we measure success in that domain, I think that's a very profound question. And I would say here and now, I don't think we have some of the measurement technologies that we need yet in order to judge, are we really making a difference? But here and at the far right-hand corner, this is the strategy. This is where we're trying to position the NHS to take that strategic view. So how are we structuring ourselves? So, why integration? Well, I've already made some of these points, but long-term conditions are now a central task of the NHS. I don't know how many of you have interacted with the NHS or have had relatives who have interacted with the NHS, but commonly what people tell us is they tell us there is an episode of care, that episode has a start, a middle and an end, but more often than not, particularly given the complexity of what I'm talking about, there will be a follow-on. That follow-on is seldom integrated. It is seldom a seamless pathway of care. So that then leads us to the next point. We need to manage networks of care, not just organisations. We've had an NHS that is focused on those very large, very visible buildings of hospitals. We now need to recognise that out-of-hospital care is as important as in-hospital care. And finally, that oft-quoted maxim, but one that I think defies definition quite on most working days, that I seem to be in the NHS, services need to be integrated around the patient. What does that actually mean when you get right down to it, I think is a question we are most definitely still grappling with. So I said, well, here's the answer to that question, or here's at least in part an answer to that question. So 5 themes, and these are 50 Vanguards. You may recognise, well, if you can locate yourself on the map, you can see whether you've got a Vanguard near you. But here are the 5 Vanguards, and they are really responding to the kind of 5 challenges that we've got in the NHS from a clinical perspective. So how do you join up GP, hospital, community and mental health services? How do you make sure that specialist care can be moved out of hospitals earlier? How do you make sure that older people enjoy better health and social care and rehabilitation services? How do you prevent the entire world feeling, that's probably an emotive statement really, it's my experience of winter, feeling like the only place it can go over the winter period is to an emergency department? How do you make sure that acute hospitals work more effectively together and reduce variation, that word variation again, in care and efficiency? So those are the 5 core clinical motifs, the 5 core clinical strategies that we're rolling out across the country in order to try and make a difference to how care is organised. And the idea is quite simple. Learn fast. If it doesn't work, fail fast. If it does work, get this model implemented. And there's rich material that you can go and see online. All of this material is available for people to look at. We are still learning about all of these things as I speak. So how are we delivering that? Well, here are the sustainability and transformation partnerships. What's different about them? Well, they bring together the NHS in terms of acute, community and mental health services, critically local government. So the out-of-hospital domain, we have to have local government partners on board if we're going to deliver, the third sector and academic organisations. We believe that the best answer to problems that populations face is not determined solely by policy frameworks, it's by creating collaboratives of organisations who can create their work plans, their governance and their implementation. It's the best way of knitting together that pea soup, that fog that we have of some of the organisational boundaries. And you can see where all of the map on the right shows where each of the STPs is, and it aggregates, that's critical, it aggregates groups of hospitals together, it aggregates groups of clinical commissioning units together, it brings together local government and makes them part of the story, it brings together the academic systems in the organisation, it says together we solve the problems of this population. That really sets out our journey. I'm not going to, but for those of you who've studied how is this going to develop, and looked at comparative organisational structures in other health systems. You can see that we're moving on a journey towards accountable care systems, perhaps eventually towards accountable care organisations, sort of a topic of a discussion in its own right, but I put it up there just as the policy context. And there you can see what we're trying to do. So by giving autonomy back to the system, we are making sure that, that this organisational system, and the key bullet point at the bottom there, is the accountability for improving the health and well-being of the population. Note both of those, the health and well-being. It's no longer enough to be great at doing treatment. You've got to improve the well-being. We've got to make sure these ACSs act on national priorities, taking the strain off A&E, making it easier to see a GP, improving access to cancer and mental health services, all of those things, but bringing people together. The only way we think this is going to work is in partnership. Here, for just in case people are interested, is where those systems are. Don't know if anybody here is in the audience is from one of those local systems. If you are, these people, these health and social care leaders, are organising themselves in a completely different way, in the way that I just described, in order to try and deliver care differently. So we're asking everybody to do this, and this is not just a journey for the few, this is a journey for the many. We think that everybody needs to be an accountable care system. We think that they need to go when they're ready. Critical, I think, to being successful in that are probably this notion of relationships being strong at a local level, the ability to take on the responsibility, and obviously to actually then be accountable for the delivery of care. And that's a summary of what we are trying to achieve in this space. One last thing I'll say on this is that all of us are patients. Every single one of us in this room either has been or will be a patient. It's just a matter of time. We know that, these proposals, these ideas that I've been talking about in this last section, need to be locally owned, clinically owned, and publicly supported. I wanted just to point out, of course, here, does this work, which is the critical acid test? Does this actually deliver benefit? I was in London, I worked as was said in London, and part of the system where we moved away very simply from, if you had a stroke, you went to the nearest local district general hospital, to if you had a stroke, you went to the nearest hyperacute stroke unit, the HASU as it became known. And you got specialist treatment, you got access to a stroke high dependency unit. In the time that that has been operating, we've saved 100 lives a year, 100 strokes who would have otherwise died. So this really does matter clinically. If we get this right, it can make a huge difference to how lives are saved. And here's another one. We moved away from, if you had a big road traffic accident, you went to the nearest A&E, to if you had a road traffic accident that required you to have major trauma centre, you went to one of 4 designated centres. And we know that that's improved the chances of you surviving those major trauma incidents by up to 50%. Those are not insignificant numbers. So you may think that this stress on the organisation of care is so much frippery, so much governance. But the point I wanted to land at this point on in the talk was to say, in actual fact, the organisation of the care has a fundamental relationship between the outcomes that are to the outcomes that are then delivered. I can tell you too that those 2 sentences describe a huge amount of, don't describe the huge amount of challenge we had to go through in order to deliver those outcomes. People had strongly vested interest in maintaining those services as they were. Right, I said I would talk now about one of the key programmes that is supporting the 5-year forward view, and I said I would talk about variation. So this is right care. And you may or may not have heard about Right Care. It's all available online, so you can go to the NHS England website. You can look up the Commissioning for Value Pack for your local CCG. You can look at your local practice and you can see the variation in what I'm about to show you. So what is Right Care, first of all? It's about, well, fairly self-evidently, delivering the best care to patients, making the NHS's money go as far as possible and improving patient outcomes. A bit Pollyanna-ish, you might think. Why aren't we doing that already? Well, the evidence suggests that there is a huge amount that we still have to do in this space, and that's what I'm now going to speak to. So Right Care has four principles. The first one is at the top. It is about local health economies. This isn't a top-down programme. This is a programme about everybody's local practice. And it has four key tasks. Making best use of resources. So are we actually spending our money in the most optimal way? Do we understand how we are doing? Do we actually understand where referral practice is variant with demographically similar populations? Do we get people talking about the same stuff? And are we focusing on the areas of greatest opportunity? That, in a nutshell, is Right Care. And our simple task is to try and get everybody in the country talking about that. So here is the process that we go through in order to try and do this. And you can see we've got a very simple set of ingredients. The key point about these ingredients is all of them have to be present. So the first one is clinical leadership. This is a clinically led programme. Clinicians have to drive the change. The second is that we have one version of the truth. I can't stress, well, some of you may have dealt with clinicians in your day jobs, and you've seen that there is often, how shall I put this politely, fierce argument over the interpretation of the data that sometimes distracts from actually making the change that you need to. So our job in this space is to create one version of the truth, one version of the truth that drives the change. We then need to make sure that there is engagement, because this is about changing the interaction between a GP and a patient in the consultation room right across the country. We then need to collect evidence that the change is actually occurring. And then finally, we need to embed new processes to make sure that the change that we've proposed actually sticks. Here are some examples of what can happen when you do this. So I gave you a kind of top-down view. Now look, here are some CCGs here. I'm not going to go through them all, but you can see just how powerful some of these changes are if you actually get them to stick. Now that's just in, 5 CCGs, but what we now need to do is to make sure everybody is doing this and everybody does it consistently. And here's one for urgent and emergency care, here's one for long-term conditions, here's another one for long-term conditions, here's one for integration and out-of-hospital care. So right across the spectrum of care. So how do we do it? So this is the analytical methodology. So there we are, we've got 209 clinical commissioning groups against their most 10 similar CCGs. And we identify their most 10 similar CCGs, the demographically similar CCGs, on these factors here. And we compare like for like. So we only compare the geographic neighbours if they're also demographically similar, because they may have good reasons for doing things differently. What do we find out? Well, here this is for Lancashire and South Cumbria, and here you can see the opportunity that exists in Lancashire and South Cumbria across a range of different conditions. Notice Lancashire and South Cumbria. So here I now link to the organisation of care point I was making earlier on. So STPs, when I look at this at a CCG level and I look, say, at the cancer data, there may be only 2 beds that might be affected if you had it at a CCG level. When I look at this at an STP level, I see a huge amount of opportunity, and the total is 237,778 bed days opportunity across those clinical conditions if everybody optimised their referral and treatment pathways, or alternatively about 651 beds. Now, some of you may have spotted, if you read the professional press, there's been a big argument, hasn't there, about whether the NHS has enough beds over winter. I'm spending a lot of my time worrying about that at the moment. We look at some of our sentinel indicators around pressure, so we know that the total acute estate is about 92 to 94% occupied at the moment. But what we also know then is that it's occupied with a great many of these patients here. And we know that if we were able to affect their care positively, we would be able to release that 651 beds. And that's just in one STP. Imagine if we got this rolled out right across the NHS. That would be a real win for us. And that's the challenge. So when you hear people talking about the efficiency of the NHS and its productivity, and you wonder what that means. Does that mean people are not working hard enough? Does that mean people are inherently lazy and, you know, we just don't have enough services? This, for me, is what it really means. It's not the story that is often told, but this is the aggregation of simple transactions at a population-based scale where either the referral behaviour is not right, in other words, people are not following the evidence for referral, so we get too many referrals into the system. The pathway isn't organised correctly, so people accrue unnecessary days' worth of delay, or the outcome is poorly organised so that the episode doesn't end with a discrete finish point. Here's another way of looking at this. So what you've got here is conditions associated with a heart disease pathway. All of this information is available for you to look at online. So here we have the conditions along here, and we have the variation. So you can tell that in these areas, the red bars here, they are definitely worse than their peers. So we know that for non-elective spend, from under 75 mortality from CHD, from under 75 mortality from acute MHI, these guys need to do better. This is data that is available at practice level. It's very powerful. The issue, of course, which I'll come on to in a second, is that it is not necessarily being used in a consistent way, nor yet is the uptake at the level at which we would like it to be. Then you can see some blue bars here. This is where you need to investigate. So what this is encouraging local systems to do is to take their clinical data and actually understand it in a way that is completely different to the way that we have done before, which is generally people work on what they're interested in, what they happen to have dealt with. This gives them access to the data in a way that is systematic, in a way that is aggregated by their CCG, and gives them a conclusion. Poorer CVD detection than peers, poorer secondary prevention, lower prescribing with significantly higher emergency spend and higher premature mortality. And you can see that you might wonder whether, if you certainly had heart conditions, whether you'd want to be living within the boundaries of this CCG. So how do we work? Well, given that data that I've just shown you, there's an improvement process. So here we've got people, so if we take the CVD pathway, the heart disease pathway that I've just shown you, you would have a team of local delivery partners who would go in to actually work out how do you do things differently. And the key thing here is implementing locally agreed optimal value pathways for the whole population. That's the challenge that we are trying to engage in across a range of care settings. I'll show you in a second what those are, for every single CCG in the country, but held by that STP. And point here is that each cycle of a change addresses the largest spend and outcome opportunities for a local population, typically over an annual cycle. And then we also try and get to ourselves to do some quick wins. And we're working on 800 pathways nationally, and here they are. So I said earlier on that we're trying to do this across a range of care settings. Here you can see the care settings where we think that there is significant opportunity. Not surprising that you can see MSK here, musculoskeletal, at the top of our list. That was identified as a really significant early opportunity. Still remains so. We're trying to standardise referral behaviour to make sure that we don't overload the secondary care system with, frankly, treatments that could be provided by a physio in an out-of-hospital setting. But you can see right across the care settings, virtually every single setting of care has significant opportunities available to it. And we need to make sure that those opportunities are driven. So what are the challenges and opportunities? I wanted to talk a little bit about why we think this will work, but also some of the opportunities in kind of the last section of my talk. So the first is that, as I've said, these are clinician-led opportunities. These have to be led by clinicians locally. We have to appeal to the people who are delivering the care. The second opportunity is that they are evidence-based. I've showed you there is a hugely powerful evidence base behind this. The third is that this is local. This is not top-down. This is you taking control over your change process locally. And the fourth is, of course, that they are replicable. Then, in a second, there are obviously three major challenges. Croc, it's not a plastic comfortable shoe, but I will talk about what it is in a second and why that is so hard. The spread of dispersion. So here's the great challenge for the NHS. We know that there are huge numbers of good ideas. Our challenge is how do we get through that huge federation and encourage everybody to do the same thing. And finally, of course, we've got a challenge about making sure there's enough resource to do this programme. So CROC, reallocation of capacity. So we think that we've got about 12,400 beds in the NHS where the aggregate variation would show that they are at the wrong end of the spectrum. So we know that there is a huge amount of capacity that could be reallocated. Why is that important? Well, in the cash-constrained environment that I was talking about, the NHS needs to live within its means. The great question is, can it live within its means? The answer, if you look at this sort of data, would suggest if we reorganise these pathways, then yes. If we don't, then no. The challenge, of course, is why are we not reorganising them faster when there is so much evidence that supports the fact that we could do better in this space. But it's not just the beds that are a problem. We know, and this is probably true of some people in this room, we've got 1 million plus people undetected with at least one of these conditions. Think about that. And think about the cost of undiagnosed emergency treatment. It was a stat, sadly it's still a true stat at the moment, that up to 25 to 30% of cancers are first diagnosed in an emergency room. So it's a real problem for us about how do we get the public to engage with screening. What we need to do here, and this is our challenge with local systems. So imagine now we've got this clinical commissioning group, we've persuaded it, it's persuaded itself that it's got to change its coronary heart disease pathway. It's worked out where the opportunity is. It then has to make sure that once it's made that change, it reallocates or shuts the capacity. Now, it's not necessarily about shutting beds, shutting services, but if we release efficiency, if the NHS is to live within its means, it has to change the way it realises the benefit, and that is about the reallocation of capacity. We've got to make sure, this is the central challenge that every single system is grappling with. It's not just enough to identify the variation. It's not just enough to implement change to the variation. When you've got the benefit, when you've got the different pathway, you absolutely have to then realise the benefit. Otherwise, we just simply incur a double cost. We pay for the old service and we haven't released the benefit in order to fund the new demand. So, right care principles. It sounds obvious, but these are the real challenges that we are struggling with on the ground right now. So we know that right care is rolling out across the country. It will be present in your local system somewhere. But we also know that people are really struggling to actually release the success of implementing change pathways to make sure the NHS can live within its means. Here are the 4 things that we would say that are absolutely essential to bring those 2 things together. The first is to get everybody talking about the same stuff. Clinicians love to discuss. They love to discuss their own particular point of view. What we absolutely have to do is to make sure local systems talk about one set of things, not everything that everybody wants to talk about. Otherwise, you're in the place where you know the price of everything and the value of nothing. You have to choose what adds value. We then have to talk about why is it not working, and we have to be honest about why this is the right thing to do for our population and why it's doable. And this is uncomfortable for systems because it involves often challenging long-held views and practices. We then have to work in a no-blame... This is probably... Well, I said that was hard. This is even harder, potentially. This is the no-blame moment, isn't it? So we have to work in a place where it's not anybody's fault, but we just need to design the optimal care for the population. And finally, we have to demonstrate viability. Those are the 4 things that we need to get people to do. So here just are a few ideas about how you then take this forward. So we've got now to a place where we've agreed that the change is necessary. We've made the change, and here are some of the key ideas that now need to be put into place. And the one I want to talk about in a second, I suppose, is logic modelling. But this idea, this implementation planning, this point I was making about phasing out old capacity and exit strategies and making sure it's embedded within the STP. And ultimately, I would say this because I'm an operations person, you have to make sure that you've got the good old-fashioned performance management in place if we're going to do that. So I wanted to turn now to a bit on logic modelling. So if we're going to do this, how do we actually get local systems to change the way that they behave? And you can see here, so we've identified reallocation model opportunities, we've agreed what they are, we've consolidated what we think the impact, but we now need to work out how that actually changes into clinical pathways. And people, no doubt you will be much more familiar with this. We start with the outcomes that we're seeking to achieve. We work backwards to the inputs. This is a process that will be intimately familiar to all of you. It is not a way that the NHS traditionally thinks about how it organises care. This is what we're trying to teach people. And we have to develop this model from the bottom up. And it has, as I've said, to be specific. It has to be underpinned by the evidence base. Otherwise, people will not buy into it. It has to have transparent assumptions. It has to show cost. And I want to show you now, just if I have it, it's gone. I want to show you just a few thoughts about some of the rules of the game. So it's got real cash releasing cost reduction. We must achieve targets. We must maintain quality. We have to stop this language of we're either shaving cost out of the system or we're improving quality. We've got to do both. That is the challenge that is central to the NHS's approach, and that's what we think Right Care delivers. Finally, some barriers. So I've talked about quite a few of these, but you can see these are the things that are in place, I think, to a greater or lesser extent in every local system. The NHS is not a new organisation. It's, 75 years old now, and historic barriers need to change. We've got to move away from blaming to improving and solving. We have to move away from organisation governance into system governance. We've got to stop seeing information as a source of proprietary commercial advantage and start sharing it across systems in a completely different way. We've got to make sure regulators join up their ask of the system. We've got to make sure that we've got dedicated time and clear delivery mechanisms. And we've got to ultimately make a view, we've got to express a clear view on where to start. So where do you start? Well, you look for variation in national data and in local systems. You have to identify the areas where real system savings can be made. And you also have to make sure critically that the incentives that drive behaviour across the system are aligned to the change that you want to deliver. And most crucially, you have to repeat, you have to be endlessly persistent in order to make the change stick that you want to see happen. So some key takeaways before I close. The first, as I've said, this data is available. You can go and access it. It's open source data, it's cut by CCG, it's cut by STP. It's available and accessible to you right now. I would encourage everybody who works with the NHS, who has worked with the NHS, who wants to work with the NHS, to look at this data. We want your input into it. You know, I said earlier on, STPs are trying to engage local systems, local academic partners to work on this data. Get involved locally, contribute. People are looking to expand and scale up this intervention. Co-working with Getting It Right First Time, that's the surgical version of the same thing that I've just talked about, really will ensure a big impact for us at a local health economy level. CROC, which is our key challenge, provides a massive opportunity to ensure increasing value and reducing unwarranted variation, but also to release capacity and with the benefit of actually maintaining the benefit of delivering the quality while living within the means. And you can follow us on RightCare, hashtag. So do follow us, because we are actively trying to make this programme work at a local level in the system. And that, thank you very much for bearing with me so patiently, is all I wanted to say, and happy to take any questions.
Thank you.